Greg Snell to introduce himself.
I'm Greg Snell. I'm a respiratory physician by trade, and I'm the medical head of the lung transplant program at the Alfred here in Melbourne. I've been involved with the initiation of DCD lung transplantation and had a lot to do with the background of DCD, and also involved at an Australian and international level with recipient selection and donor selection for lung transplant.
I'm Nicole Gauthier, and I'm one of the organ donor coordinators for Donate Life Victoria, and my background is ICU, nursing, and heart and lung transplantation.
I'm Dominique Martin, a bioethicist from the University of Melbourne. I'm co-chair of the International Transplantation Society's Ethics Committee and a member of the Declaration of Istanbul custodian group. Any of the opinions that I might express here today should not be taken as reflecting the position of either of those organisations.
I'm Helen McCann. I'm an ANUM in ICU at Monash Health, and that's pretty much all. I haven't got as much as you've got to say about yourself.
I'm Victoria Ryle. I am a member of a donor family. My daughter died of a traumatic brain injury 2.5 years ago at the Royal Melbourne, and I'm here in some way to represent the perspective of donor families, although of course I cannot say I speak for them. I have also asked Jerry if he would place a chair here, an empty chair following the tradition of PEN, the International Writers' Rights Group, and this empty chair represents the donors who of course cannot be here. I hope I have some useful things to share in this conversation without the medical knowledge, obviously, to participate in that aspect.
Thank you, and I'm Steve Philpott. I'm an intensivist at the Alfred Hospital and Hospital Medical Director for Organ Donation. And it's my pleasure to present the cases that we'll be using as a scaffold for the discussion today. As we walk through the case, there'll be a number of points where we stop to vote. At all of those points, you'll be asked a question for which there is no right or wrong answer, and we will ask you to vote. Just remind you that when you get to this page on the voting system, there's no need for you to log in to place your answers. What we've asked is for the members of the panel, rather than voting using an app, they are going to disclose their vote by holding up a card with the answer that they have chosen on them. And there'll be many questions which they may abstain from, which are outside their area of interest or expertise. And Jerry is roaming the audience with microphones, and we'd certainly, as Jerry said, encourage anyone to raise your hand if you wish to be involved in the discussion. So our first patient, I should also finally mention that these cases are fictionalised in order to introduce the various areas of discussion that we hope to cover during the session. So our first patient is a 42-year-old man who was working on a scaffolding rig cleaning gutters when the scaffolding collapsed. He fell to the ground about 2 metres and struck his head. And when his co-workers found him, he was unconscious but breathing. And indeed, that's how he was when the paramedics arrived 5 minutes later. They found that he had a GCS of 3 with fixed and dilated pupils when they arrived. Shortly after their arrival, he had a witnessed but not monitored VF arrest. He received a total of 4 minutes of CPR, and when the defibrillator pads were applied, his rhythm was VF, and he had return of spontaneous circulation after the second shock. He was intubated during the arrest and commenced on an adrenaline infusion immediately afterwards, running at 20 micrograms per minute. He was placed in spinal precautions and taken to the nearest emergency department. When he arrived in the emergency department, he remained with a GCS of 3 and fixed and dilated pupils, having received no sedation whatsoever. His temperature on arrival was 34 degrees, and over the next few hours he was gradually rewarmed to 36 degrees. He had an arterial line and a central line placed. His adrenaline infusion was weaned to 5 micrograms per minute, and he had no further arrhythmias in the emergency department. A CT scan revealed a severe traumatic brain injury, and CT scan of his cervical spine demonstrated moderate degenerative changes and an isolated C7 spinous process fracture. In light of the cardiac arrest, he had an ECG performed, which showed no evidence of any myocardial ischemia, and a brief bedside echo, which demonstrated no regional wall motion abnormalities. Both cardiology and neurosurgical teams were involved at this point. The cardiology team felt that there was no indication for them to intervene and were keen for a neurosurgical assessment first. The neurosurgeon said that his brain injury was unsurvivable and that there was no role for operative intervention. So we're going to pause at this point for the first audience question. So the family are approached, and it's explained to the family that this man has an unsurvivable brain injury and he is going to be taken to the intensive care unit. Will you discuss organ and tissue donation in the emergency department before taking the patient to the intensive care unit?
Is there any ethical reason we shouldn't have a conversation that involves organ and tissue donation before admission to the intensive care unit? Do you think one way or the other?
There are obviously ethical concerns which are very closely aligned with the clinical concerns about commencing this sort of discussion in what's probably a very acute, emotionally traumatic situation for the family, for the staff. I don't think that there's any reason that this should be ruled out, and obviously in many parts of the world this may be the only opportunity that there would be for a discussion, and hence the opportunity to preserve the possibility of organ donation. So I think I would certainly, I'm voting yes on this, that it could be discussed, perhaps rather than should, because if there is the opportunity to discuss this shortly, perhaps, or soon thereafter, or the following day in ICU, I don't think that we have to have this discussion here at the moment with the information we have available to us. But if the situation were different, if we were making a decision about whether this patient does go to the ICU or not, then that may be something where it is time critical and we have more pressure to have the discussion now. Does that sort of make sense?
Thank you. Nicole?
I just wanted to suggest maybe that some of the yes votes could be from individuals that work in a hospital that the person wouldn't actually make it to ICU if they were determined to be to have had an unsurvivable brain injury in the emergency department. That there will be some individuals that work in a hospital where they're not admitted to ICU, they are palliated in emergency. So the opportunity for organ and tissue donation would be completely lost in the situations where organ donation wasn't raised in the ED because they would be palliated then. And it would be too late.
Victoria, I'd like to throw to you as well, if that's possible.
Yes, of course, this is a revelation to me that those sorts of considerations were going on, and I'm sure it was a finely balanced thing, but certainly the moment Scarlett was moved to ICU, we actually raised organ donation, and there was a sense of, oh, no, we're not ready to talk about that yet, we mustn't talk about that yet. But I would certainly say at the earliest possible opportunity, it's only fair to raise it.
For me, there's a balance here between ensuring that there's no ambiguity as to the reason why this person with an unsurvivable injury is being admitted to the intensive care unit, and at the same time wanting to be sensitive to the family's needs in determining the timing of raising organ and tissue donation. I'm interested, Victoria, you said that you raised it yourself. Was that done in the emergency department or in the intensive care unit?
No, to be fair, it was done up in ICU, but quite early on. No, we were obviously told that they were going to give her a chance. They operated, and we were told very early on that it was a very, very slim chance. So I guess maybe she was on some sort of borderline, and therefore it wouldn't have been appropriate to have palliated her in the emergency department. But yes, I mean, sorry, yes. Yep.
Could I ask, is there anyone who feels strongly that not under any circumstances should organ and tissue donation be raised in the emergency department, who would like to share their views with us? Thank you, Rajiv.
Hello. I actually would vote no on the basis that it's clear that from the scan and everything that the outcome is very poor. I really worry about approaching families straight away, because you're just explaining to them that the outcome is poor and straight away raising this issue, and sometimes there can be an adverse reaction to this because they're just trying to cope with the devastating news that this person has died. So I personally would have taken the patient to intensive care unit and raised this, if this is in the evening, probably raised it in the morning. My question is, why, whoever said yes, why, what is the hurry? Hey, what's the hurry in raising it straight away, mate? That's my question to those who have said yes.
Thank you. There is one hand.
We'll take that as a comment. Thanks, Rajiv. I guess the issue is one of disclosure, isn't it? Whether admission to the intensive care unit with the likelihood of a very poor outcome raises expectations on behalf of the family, or whether or not it is, if we're transferring somebody to the intensive care unit expressly for the purposes of exploring organ and tissue donation, we should be honest about that. Okay, we're going to take one more comment from the floor and then we're going to move on.
I think the decision of yes or no depends on where the patient, where these people are coming from. In our hospital, we will not admit the patients purely for end-of-life care. If anything is not going to improve in ICU, we'll actually disclose to the family that it's not going to come. And most of the times we'll be palliating the patients in ED. So if they are coming to ICU, it is imperative that we tell them that organ donation is something that we would be considering. And therefore we have to raise it. It doesn't mean that we should raise it. We could raise it. Sometimes if this family is not really ready for it, we may not raise it. But whether we could raise it, yes, we could.
So apologies in advance for those with their hands up that didn't get a chance to talk there. We are going to keep moving because we've actually 16 questions to get through. So the donor register is accessed and the patient is not registered. It's explained to the family in ED that there is an opportunity for organ and tissue donation, and the family expressed some interest in obtaining more information about this and asked for some more time to think about it. So the patient's brought up to the intensive care unit. He's now been in ICU for 12 hours. During that time, he's been in an apneic coma with fixed and dilated pupils, an absent cough reflex, and a GCS of 3. The family are briefed about the likelihood of brain death and explained to them that tests will be done to determine whether this is the case. Your next question is, in light of the risk of a cervical spine injury and the findings of the CT scan of the C-spine, is more imaging of the spinal cord or other investigations of cord integrity required before a clinical diagnosis of brain death is pursued? So it seems that's a fairly dominant answer of no there. Was there anyone who answered yes to that question that wanted to explain why they felt more imaging was required? Helen, down the front.
I'm not sure if I'd undertake an MRI because of the logistics of that, but I felt uncomfortable in that there was a fracture of the spinal process of C7 and degenerative changes, and I wonder whether there could be spinal cord injury that is not apparent from CT, and if there was, that could then make the clinical examination, particularly motor response, unreliable, and also apnea testing. So I think that's the concern I have.
And anyone that would like to put forward an alternative opinion? So the following question, the next question is along a similar vein, and it's simply, should we always do some form of imaging test, and by that I mean either nuclear medicine or four-vessel angiography, when we determine brain death?
Did anybody want to comment on that while we're voting?
Simon Platt from St Vincent's. If you answered yes, then that's going to limit a number of people where they come to facilities that don't have that possible.
So I think the comment was that there are going to be hospitals where imaging confirmation is unavailable, is that right? Okay. So just a reminder that when this patient arrived to the emergency department, their temperature was 34 degrees and they had had a brief period of cardiac arrest. They were rewarmed to 36 degrees after 4 hours. If we are going to use clinical testing to assess for brain death, should clinical testing be delayed by 24 hours, given the short period of hypothermia and the short period of cardiac arrest?
So I guess this particular conundrum may become less common in clinical practice as the place of therapeutic hypothermia remains uncertain with recent publications, if anybody wants to comment on that.
Hi, I'm Craig Walker from Monash Medical Centre here. This is what I hate about multi-choice questions. It's the wrong question. Clinical testing would have to be delayed but the same reason for the spinal cord injury. In this case, you've got a patient who clearly has an unsurvivable injury. You suspect he's brain dead quite early in the piece. This would be the case for imaging to look for brain death rather than waiting, because you know he's brain dead. Waiting for appropriate signs to do a clinical test is just wasting time because nothing's going to change. And also with the spinal cord injury, theoretically you cannot do a proper clinical test. So both these things go together. In this particular case, and I assume this case has been thought out quite cleverly, it's a fictional case who's clearly got no survivable, no hope of survival and has probably gone to brain death quite quickly. But you can't do a clinical test on this guy because of his spinal cord injury. I wouldn't be imaging the spinal cord. I would be looking for, if he's got fixed dilated pupils, I'd be looking early on for any perfusion of his brain and sorting out brain death, yes or no, very quickly.
Thank you, Craig.
James down the front.
James Judson from Auckland. I disagree with the previous comments. One, it's not clear whether or not there is a spinal cord injury. If there is a spinal cord injury, then it's below the level of the phrenic nerve, so breathing would still be possible with this degree of spinal cord injury. So we can determine brain death by clinical testing. In the case of the cardiac arrest, this is incidental. The cause of the brain injury is clearly traumatic brain injury. It's got nothing to do with the cardiac arrest or the hypothermia. The ANZICS guidelines are quite clear. When they refer to hypothermia, it's therapeutic hypothermia after cardiac arrest, which this patient didn't have. He just happens to have got a bit cold during the resuscitation process. So I would definitely advise, if anyone phoned me, and they do, that we don't need to wait 24 hours. We would need to wait 4 hours. They'd need to be at 35 degrees or above for the 4-hour observation period, and then clinical testing could go ahead.
Thank you.
So a strong message there. If you know your ANZICS guidelines, you won't go too far wrong.
So let's assume that it's now 24 hours since the patient's injury, and for sake of moving the case forward, brain death has been confirmed by a nuclear medicine scan. The family have given consent for organ and tissue donation, and at this stage the patient is on 20 micrograms a minute of noradrenaline, 2 micrograms per minute of adrenaline, with a heart rate of 100 and a blood pressure of 86/50. They are on 45% oxygen and have been oliguric with a urine output of about 15 mils per hour. History has revealed no history of smoking or alcohol and no significant medical history. They have normal renal and liver function tests and a PF ratio just under 200. we could go to the next question. For this brain-dead potential organ donor, what do you think should be our target blood pressure?
So I might just, while we're voting on that one, ask Graham Starkey, who's with us, who's a transplantation surgeon, whether or not, from a transplantation perspective, I have any view about organ perfusion and what we should be doing.
Thanks, Jerry. Graham Starkey, liver surgeon. I don't consider myself an expert in management of brain-dead patients, but we want the organs to be well perfused, and therefore I would have thought we're looking at similar parameters to anyone who's in ICU. So my answer would probably be in the middle one, a map of more than 70. When we get a donor story like this, no matter what the blood pressure's been, we're going to go and have a look and aim to procure the organs.
Was there anyone with a strong opinion about one of those answers?
Did you want to comment, Greg?
I think it's from thinking with the lung hat on, it's a matter of the balance between improving the blood pressure with too much fluid or too much inotropes, and in some ways it's that combination. And the number's not important. In some ways it's a little bit how you get there will determine the kidney and the heart and the lung function. So you have to be careful not just going for a target.
Can I also put my nursing and heart hat on? If you say we are aiming for a map of 60, ICU nurses will probably aim to not go below 60, so we'll hit somewhere between 60 and 70. Not quite having your target at 70 allows to minimize use of vasopressors and things like that, so that we're looking at, after brain death and once organ and tissue donation has been raised, we're looking at organ function and quality, and so minimizing vasopressor use and fluid challenges for heart and lung and donation in the future would be my opinion on that.
Okay, thanks, Nick. And a follow-up clinical question to that. For all brain-dead potential organ donors requiring inotropes, should we administer hormonal therapy? And by that I mean thyroxine plus or minus vasopressin and steroids. And anyone that wanted to comment on their answer for that? Greg, did you have any specific comments about that?
I think there's good evidence, good medical evidence that you get if you're going to have an organ donor from this situation, then the organs are going to be better if you've had the cocktail. I think there's solid evidence for that. The downside is cost. And, I'm not aware of a medical downside.
Comment from you, James?
I don't believe that there is, in fact, RCT evidence in favour of hormonal resuscitation. And again, this is covered in the ANZICS guidelines, and hormonal resuscitation is not recommended.
So I'll just ask James a question, if I may. So do you think that the ANZICS guidelines are sufficiently evidence-based to have covered that particular question?
They're a couple of years old now. There's probably more recent evidence. I see Helen's desperate to say something.
As a significant contributor to that section in the ANZICS statement, it's actually quite open. It's a bit of an evidence-free zone, and I think the problem perhaps with the question is it's talking about any potential donor, and I think current practice would be that people would consider hormonal supportive therapy, so thyroxine, T3 and steroid, in patients on substantial doses of inotrope, like this patient, or patients being considered for heart donation who on echocardiography have a potential usable heart, but the function's a little bit suboptimal. But it's not routinely given to all potential donors.
Thank you. And with respect to management of potential organ donors, should all post-mortem investigations require specific consent from the next of kin in a patient who's brain dead? And by that, I guess we're referring to blood tests as well as the more invasive investigations.
So we have a yes from Virginia on that and a no from Dominic, so I'd really like to get a comment from both of you.
Dominic, did you want to comment on your no? Sorry, Jerry.
No, I don't think that all post-mortem investigations require specific consent. I think not only would that be burdensome, but that could potentially be burdensome in the sense of harmful to families, the next of kin. So that's not to say that informing them about what's happening and getting consent for particular investigations is not critical, but I don't think that that encompasses an obligation to do that specifically for every single investigation.
Victoria, could we ask you your feelings as someone who's experienced this? Do you remember giving consent for procedures, and how did it make you feel if you do remember that?
Just to clarify, post-mortem investigations after the donation.
Oh, sorry. So to clarify that, after brain death has been determined and before organ donation surgery.
Okay. In which case I'd probably change my answer to no, because I agree, I probably wouldn't want anything. No.
Mm-hmm.
No.
I think with sort of minor investigations, taking a blood test to, check for matching and so on, I think a lot of that, there's very good reason to presume consent there. You might say, this is the reason why we're going to do some blood tests, and a lot of families perhaps would like to have that level of detail. But certainly if we're talking more invasive investigations, if we're talking bronchoscopy, or as I think we're coming to some questions about more significant interventions, then whether it's certainly it's a consent process, but certainly there needs to be more explicit details about those potential investigations presented to the next of kin.
And Victoria, do you have any reflections on your experience of the consent process for organ donation?
I think overall, on the whole, I could summarise it by saying I think there needs to be more conversation but less bureaucracy in forms. So I think probably less explicit, more human interaction, more very direct listening and talking. But I don't think anybody, when you're in such a state of shock, can cope with having to make very specific decisions. I think it's better to keep around the general decision. Personally, I think the focus should go far more into building the donor registers so that the decision is made by the live person, and promote that so that there is less emphasis placed on the family at that time and more focus on the quality of the dying, because, obviously that's what's got to be remembered, that it's, of course, of huge value to you in the transplant process, the body, but actually what the families care about is that their loved one is dead, dying, and it's an extraordinary process, obviously, to be in this limbo of knowing that she's dead, but having a body that's being kept alive on support. And so I think that for me is where there needs to be some more work on the kinds of conversations and how you handle that process. But I would say that, the less detail at that stage, the better, the more humanity.
Thank you. Okay, so things are about to get a little bit woolly here. Now, our patient's best friend has arrived and has asked to meet in private with the donor coordinator. And he's told the donor coordinator that the night before this patient's injury, they were out partying together, and he thinks, although he's not certain, that the patient for the first time ever experimented with injecting drugs. He's unable to give any details about it, and we're unable to find anyone who was actually present at the time. The serology has returned negative, including nucleic acid testing. And the question is, assuming there are no suitable Category 1 recipients, should he be deemed not medically suitable on the grounds of risk of transmission of blood-borne viruses? Now, I might ask Nick to talk to this first.
The first thing that in this situation that I would be thinking about is how reliable is the information that we're getting. I'm guessing we're probably only about 36 hours-ish after the injury, And sorry, how many days before was he?
So it's now 3 days ago that this possible injecting drug use took place.
And I think that the information that we gather needs to be considered in the context of risk versus benefit, to risk to the potential recipients versus benefit to them. So one of the big things that I would be doing is looking for some corroborating information around how likely or what is it an actual fact that they used injectable drugs, and what the likelihood of contracting a bloodborne virus from one use. Obviously, we wouldn't ever be able to rule out the presence of HIV or hepatitis C because of the NAT window. We would still be within the NAT window. But I think that the information needs to be handed over to the transplant units to start making decisions about risk versus benefit for their recipients, rather than us empirically saying that they wouldn't be suitable based on risk.
So with that in mind, I might ask Greg and then Graham to comment.
This is a situation we commonly get. There's many areas of grey, and we use whatever information we get. We take whatever opinions that Donate Life's got, and we essentially run it past our own infectious diseases colleagues. And the typical risk they'll give us is that there's a 1 in 50 to 1 in 500 chance that something will be transmitted, and the risk benefits then has to be assessed. Perhaps if it was that high a story, we would actually specifically consent the recipient, but sometimes we don't if the story is even greyer than that. So it's a common scenario we have to deal with.
Graham?
Yeah, thanks. I would just also add to that, from a liver point of view, we can pick a recipient who's already got viral hepatitis, and our waiting list mortality for a liver transplant's of the order of 15 or 20%, which is going to be a hell of a lot higher than whatever the risk is here. So we would most certainly consider the organ in these circumstances.
And Greg, you mentioned briefly some thoughts about what we would disclose to the potential recipient in that situation. Are you able to tell us a little bit more about the conversation that you might have with a recipient in this setting?
Transplantation's a complex sort of moving target at 2 a.m, and as to when even it's going to occur and the exact size and quality of the organs. And it's not routine to tell the recipient anything at that point. They've been sort of briefed in the weeks and months beforehand. If there's a specific risk that's beyond what would be expected, then that would be specifically discussed and signed off. And virtually to a person, the person never says no when that's raised. And they recognise the risk benefit, 1 in 500 risk versus the waiting list mortality.
And for someone waiting on a renal transplant, where obviously the risk of not being transplanted is much lower, I'm wondering whether patients, when they go onto the renal transplant list, are asked what degree of risk they're prepared to accept when it comes to receiving an organ.
I would be surprised if they're specifically, if they rate their risk. I think you'd find that it would be common in this circumstance for the renal team to ask the individual as well, and likely that they would defer the chance.
And anyone who wanted to comment about that consent process in the high-risk marginal donor? Okay. So we actually have found another person who was at the party who can confirm that whilst drugs were smoked, they weren't inhaled and nothing was injected. And our patient has started to develop some quite significant looking T-wave inversion on his ECG. He's a 42-year-old lifelong non-smoker. Does he need an angiogram? And we've got some of the medical consultants for Donate Life in the room, I think. Is there anyone who wanted to speak to this question?
And it's quite an interesting question because the rate of heart donation in particular is lower from states without a cardiac transplantation program than it is from states with one.
little anxious because I saw Greg put an N up and he works closely with the Alfred team, of course. And I know he's 42 and he has no particular risk factors, and I'm trying to remember the criteria for an angiogram. But I would think if the heart was being considered to be used for transplantation, we would discuss it with the heart transplant unit to see whether they wanted an angiogram, and with it in mind, with, of course, whether that could be facilitated depending on the hospital. I mean, it's possible the ECG changes are secondary to the intracerebral injury. It's a bit unusual that they're just appearing now, and we don't know about other cardiovascular risk factors for this male who may have a strong family history, hypercholesterolemia or other risk factors for coronary artery disease. So we would discuss it with the heart transplant unit and seek their view.
Dave, did you want to add anything to that?
I haven't really got anything else to add, actually. Helen said it all. I think if we were in a centre where access to angiography was very difficult, I think it would be reasonable, given that if there are no other risk factors, to proceed without an angiogram, though, in this situation.
So thank you. That's a really nice segue to the next question, which is, in your hospital, would an angiogram be feasible to obtain? Are the risks to the kidneys of the contrast load considered when making that decision, or would you just do what the heart transplant unit asked for? And along similar lines, to what extent should the ICU physician be involved in the decision-making process around these investigations?
It's not really of interest to the ICU physician ultimately. I mean, it's a tension between potential harm for the transplant outcome and the potential benefit, and this person with normal renal function, presumably, the contrast load is not going to cause a problem, and certainly not a permanent renal problem. Even if there was some renal dysfunction, a contrast load seldom causes any major difficulty. So I don't see that there really are major concerns in terms of renal transplant outcome as a result of coronary angiography being performed to assess heart function.
Okay. Stuart?
It is true that every time you move someone, though, from ICU, you potentially destabilise the situation, you collapse the lungs, you take time, you get contrast allergies. On one potential donor, we've definitely dissected the left main coronary artery, and the person actually needed, this was a domino for a heart-lung transplant, and the person's heart was perfectly fine. But on a well person, they dissected the left main, and he had to have a heart-lung transplant instead of a lung transplant.
Stuart Moody from Adelaide. It's a bit louder. One of the things we found with increasing use of angiogram is the timeline and the time from diagnosis of brain death to the organ donation operation. And I often have concerns about what that puts the family through. Sometimes we can be going beyond 24 hours to 36 hours. And I think that's a consideration we need to take in mind when the angio can interrupt some of the other processes that happen. And that's certainly our experience.
Can I just throw that to Helen, who's no doubt experienced family members and the weight that they have whilst the donation is organised. In your experience, what is the effect that has on family members?
I actually think it's quite varied. Some family members want more time, and others just want to get it over with. Yeah. It's varied. It's such a complex, or families are such complex entities that, there'll be some people that want more time and they're, delaying. They want a family member to come from overseas and they're just sort of looking for all sorts of reasons to delay. And others, as I said, what are we waiting for? Let's get it over with.
And we might actually touch on that in a moment. Victoria, did you want to add to that?
Well, I just want to point out that we probably are all part of families. So just to remember, it's not just they, but we as people are all very different and diverse. And so, yes, of course, I agree that different things. In my experience, in our experience, we were waiting for my sister to fly from Europe. And there was no question of anybody suggesting that there was a choice, that I think we were being managed by the team incredibly skillfully, and they knew when she was arriving And lo and behold, the time of death was pronounced a few hours after she'd arrived. And looking back, I think, it was being managed. But at the time, it was a matter of there being a sequence of events and each decision led on. We weren't aware of that, of there being choices. And I think that's quite right. That would have been awful if it had been shall we, shan't we.
Thank you. So as the donation case is being organised, the family have again asked to speak to the donor coordinator, and they've said that whilst they understand that their loved one has died, they very much would like to be there when the heart stops beating. Is it okay for us to tell the family that this decision would mean that someone who's waiting for a heart transplant will miss out and may die? And I'm not suggesting that that's how you would say it, of course. Would anyone like to comment further on their answer?
I think with the important clarification that that is not the way you'd explain it to the family, I think this is a key part of the informed decision-making process, the consent for donation, to not explain the consequences of that choice for them, to make it clear that it is a choice, but to not explain those consequences, I think, would be a grievous failing. If they were to subsequently discover that the reason why the heart wasn't donated was because they made that decision, I think that would be a really bad outcome.
Jerry, have you got a comment from the audience there? Yep.
John Goward from Sydney, hello. Just exactly what you just said was going to be my response. I think it's our responsibility to give full information, because it would be awful to find out that you couldn't have gone through, you didn't go through that operation to transplant a heart because of that decision.
Can I say something, Steve?
Yes, Nick.
I don't know. I said yes, but with the caveat that I probably wouldn't say, somebody will miss out from a transplant and may die. I would probably just make sure that they understood what the consequences are. And I think we sometimes forget what families that don't have anyone who is medical or in nursing or anything understand about donation. As a coordinator, we often get comments in our discussions with families about how it would be nice to be there when their heart stopped. And when we explore that a little bit more, they definitely retract wanting to be there if it means that the heart isn't able to be donated, or perhaps the liver isn't able to be donated if we go down a DCD pathway. So I think we sometimes assume that people know more than they do. And I agree with Dominique and the person in the audience that it would be terrible if we didn't make that clear.
So assuming that we were unable to move past this and the family really did insist, the next question is, what would you allow what would you do in this situation? Would you ever consider allowing the family to come into theatre, or would you proceed down a DCD pathway? Obviously a lot of you have been into the theatre in one of these procedures.
Did anybody want to comment on this?
Hi, Sasha. I'm nursing from Monash. I think, there are things that are sacred, such as your family members to you, and as a healthcare worker that's exposed to things that anyone that's not medically related, it's confronting. Just coming to an ICU for a lot of our patients and their families is confronting. And as, trained professionals, going into a theatre is another level beyond that. So I don't know how we'd ever prepare a family for going to theatre.
Thank you for that comment.
Scott Simpson from Townsville. I'm sorry, I feel suddenly this question's raised a few emotions in me, because as an intern I went to my brother's donation, and I totally regret it. It almost stopped me doing intensive care as a career. So I can't possibly choose that option or put anyone else through it.
Thank you for sharing that.
Thank you, Scott, for sharing that with us. I guess it does raise, though, that issue of how you tease out some of those situations. And I mean, for me, I have to say I found it very confronting when families started to remain in the room for pediatric resuscitation. And now that's pretty standard practice where families remain in the emergency department when you're resuscitating a child. So I think there's more to this. So if anybody wants to sort of reflect on what relevance that might have.
So we are going to move on to the second case. Now, our next patient is a 28-year-old who has had a motor vehicle accident and has suffered severe pulmonary contusions. They have no other significant injuries. They're intubated on arrival to the emergency department and develop progressive hypoxia and ARDS. On day 3, they are failing high-level ventilatory support and VV ECMO is initiated. The ECMO support is complicated on day 5 of the patient's admission by an intracerebral hemorrhage. He's assessed by the neurosurgical team as well as a neurologist as having had a devastating injury from which a good neurological recovery is extremely unlikely. And the process of making this assessment has taken 2 days, during which time the patient has shown no signs of progressing to brain death. A lengthy discussion or a series of conversations held with the family, and it turns out that the patient's sister has previously suffered a head injury and this has left her debilitated. And as a family, they've had many discussions about the importance of quality of life. They are very confident that this patient would not want ongoing aggressive management if there was little chance of him leaving hospital and returning to work, or if he was going to be left with a neurological disability. It's therefore decided that ECMO support and ventilatory support be discontinued and the patient allowed a natural death. And this decision is supported by all members of the family as well as the hospital team. Organ donation is discussed and the family feel strongly that this is something that their loved one would have chosen for themselves, and they've given consent for donation after circulatory death. So the first question about this case is, would it be ethical to, now it says continue there, but in fact restart heparin in order to maintain the ECMO support whilst the organ donation is being organised, given that it may extend the intracerebral hemorrhage?
I feel like this is a really loaded question.
I'm surprised by the result, I must say. Dominic, would you like to have the first comment?
Is it ethical to continue or to restart heparin in these circumstances? I would say yes. I think that the interests of this individual, of the family, in having that opportunity to donate organs is a really significant interest, and we need to do our best to further that interest. And it sounds at this stage, heparin obviously is critical potentially to that outcome. The little addition at the end of the case to say that this could lead to an extension of the hemorrhage and presumably hasten death is probably what concerns us or causes me to pause and think, well, what be the implications of that? And here again, I'd say I still think it's very reasonable and ethical to do this, but I do think it's important to stop and reflect on the potential implications of knowingly performing a procedure or an intervention that may hasten death in these circumstances. Because if we lose sight of the significance of that and what we're doing and those other potential outcomes, then I think we lose sight of this particular individual as a person who is not dead at this stage, so who does have other interests potentially in not being harmed and so on. We want to make sure that we're not just instrumentalising them for the purpose of obtaining those organs.
Would it not go against the dead donor rule in that this procedure or therapy, which is being invoked purely to optimise the donation outcome, might contribute to the patient's death?
I believe technically to violate the dead donor rule, you have to take the organs prior to their death. So if the patient is not dead at this stage, then doing something that will hasten that death is certainly undermining the spirit of the dead donor rule, but it's not technically violating it. Hastening death in these circumstances is merely a risk. If we were able to quantify that, we knew this was a highly probable outcome. In fact, it was more likely that rather than preserving this opportunity for DCD, in fact, we'd extend the hemorrhage and they'd be brain dead within moments, and then we could declare them dead, get the organs. Then I think that's something we'd need to take very seriously. To my mind, and this is where I'm obviously not an expert, I'd like to know a little bit more about the risks, the probability, and the timelines that we have in mind for those potential results.
Thank you. Thank you. James?
I don't see how giving heparin could hasten death. This person has a devastating lung injury and a devastating head injury, and death is going to occur when ECMO and ventilation are stopped. And giving heparin is not going to alter that time frame.
Thank you. Okay. Now the family have requested that withdrawal of ECMO and ventilatory support be delayed by 3 days because they have a family member overseas, and that's the earliest that they're able to arrive back. The family member was the patient's close friend, and the family believed that it would have been a wish of the dying person to have this family member visit prior to their death. Is it okay to wait several days to allow visits from family and friends before withdrawing ECMO and ventilatory support?
Virginia, would you mind making a comment about that? Because I know
Victoria.
Victoria.
Oh. Well, all I can say is that the way people die is very important, and I don't think it can be discounted. I mean, obviously, it's there are many things being weighed up here, and the organ donation process is what's of concern to the medical team. But I think in the bigger picture, it is extremely important to, in what is obviously an incredibly difficult situation, to provide a decent environment for dying. But if you can hold on to allow people to be there, I think the knock-on effect on how the family are able to grieve would be hugely changed, and it shouldn't be left out of the conversation. It matters how people die, and if there's anything you can do to improve the experience and allow it to be taken into the future in a more positive way, then it should be definitely considered important, and where there's flexibility, it should be allowed for.
Sorry, Victoria, to cut you off there. Damien?
Yeah, Damien Hurrell. I'm a nurse donation specialist at Bendigo Health. I did vote yes. I think that in many cases it would be appropriate, but there are also circumstances where I would be looking to counsel the family that, in fact, for this person who is not yet dead, has surviving brain function, that if they were actually suffering during the time when their loved one was waiting, that may not actually be, on reflection, something that the family would support. So I would want to, with awareness of the particular circumstances of the case, communicate very clearly with this family what the consequences of that decision might be for the person involved.
Thank you. And Dave?
Take on some of the things that Damien said. I guess in the ICU we're concerned about ongoing support of a patient like this when we feel that we may be delaying donation. That may be potentially because we're concerned about ongoing suffering for family, or increased use of resources, or there may be many reasons. An additional aspect to consider sometimes is that continuing on treatment actually can lead to less likely donation of specific organs in certain situations because of deterioration in the physiological status of the patient. Sometimes having those discussions with families makes them understand that sometimes it's actually donation is more likely if you don't wait. Having said that, if the family and the ICU are prepared to continue ongoing support for a number of days, I don't personally see a problem with it.
I'll just take two more quick comments from the audience. Sam?
I also voted yes, so Sam Ratford from Austin. I would be happy to consider opening the door to prolonged period, but I think you have to check in numerous times a day, both on the patient and the family, and check that it's still the right choice for all parties.
And Stuart?
I'm just conscious that we're running over time, and I mean, I think if we're happy to continue, then obviously that's wonderful. But people may have travel commitments and so forth. So
we've probably got about 5 minutes left, and we might take just very quick comments from the audience then, if it's.
Just quickly, I also voted yes. I think the well-being of the family is probably in the best interest of the patient who's dying, and that to me is paramount. There are obviously other factors that need to be communicated, but to me that's probably the priority.
Thank you. So during the patient is now in the operating theatre, and during explantation surgery there's an iatrogenic injury to the renal artery. Should this be disclosed to the recipient?
I'll just get a quick comment from Graham on this one. I did pre-warn him.
So I think any transplant recipient is going to have been consented for vascular complications after the transplant. So I think the issue here is to what degree is this injury going to add to the risk of an arterial dissection. So I think the recipient surgeon needs to have a look at it, and then she or he needs to decide whether that is going to significantly change the risks, and if they feel that it is, then that discussion needs to be had. If they think that it's going to make negligible difference, then I think there's no need. Most of the time that'll probably be the case, I think.
Okay. Now, taking a step back and assuming instead that the patient has not yet gone to theatre, and in fact the surgeons aren't in the hospital yet, they're on their way in, and theatre have indicated that they will be ready for theatre within 45 to 60 minutes. The patient has a VF cardiac arrest. Is it appropriate to defibrillate and resuscitate the patient in order to attempt to achieve a return of spontaneous circulation to preserve the donation opportunity?
We appreciate we're asking some really tough questions, but these really are the kind of things that are happening in our hospitals, and having a sense of what people think about them is very valuable.
Greg, could I ask you for a comment?
From a selfish point of view, we can use the lungs, and they're better off if they're not pushed and prodded around and beaten up in fluids and the like. So we're happy to proceed to DCD, I think, in that circumstance. From a cardiac point of view, they'll be anxious about the organs anyway. You might still get kidneys out of it. But it's also, as in a number of these steps here, you have to recognise that this is about protecting a precious pathway. And if you ever reach critical points where you really can't make up your mind, then you've got to err on the side of not using that particular donor. And if this is going to upset anybody involved, then you're better to have that ICU happy and come back another day and explain to the family that this is not the right time to do this.
Okay. Is there a risk to the family of having gone through the process of organ donation only to see it fall over at the last hurdle?
There is, but it's also got to preserve the system. You can't have the ICU nurses, the ICU physicians all upset and the surgeons saying we're not going to use them anyway and a big argument taking place. It's better to preserve the system.
So we're just going to take two quick comments.
So thankfully I've not been in the position where I've had to decide post an arrest that we needed to get on and do this, but twice I've had a discussion with families and with staff when the cardiac arrest looked imminent, and we've got a 50% take. So one family said yes, it would be absolutely appropriate, and the staff were committed to it, and in the other the decision was no. But again, there are sometimes precursors, but in this circumstance.
Thank you.
Hi. I think, I would hope that if you're already undergoing that process, that at some point, we've all experienced working with someone that's leading up to donation, they can turn unstable. That conversation's been had is for any unforeseen reason this patient were to arrest, this isn't a brain dead donor, what would you like us to do as a family? What would work for you as a family, and what do you think your family member would want in that situation? I understand there are issues around that, but I would hope that some way we're having a discussion that would lead us to be prepared for this scenario in the event it does occur.
We'll walk a microphone up to you, Dave, while we bring up the final question, which is probably perhaps the most controversial. And that is that if ROSC can't be achieved, is it reasonable to continue CPR until the operating theatre is ready in 60 minutes' time? Dave, did you want to comment on the previous question?
Yeah, I mean, my answer might lead into this. If the family's consented to donation and the family are keen for donation, I'd do everything that I could to make donation happen. So I'd definitely defibrillate that patient and I'd start doing CPR on that patient. The question for me would be how long I'd continue doing CPR, knowing that the longer that went on, the likelihood of having viable organs and actually setting up theatre becomes less of a realistic possibility. So I probably wouldn't go on for 60 minutes.
And you could, of course, you could convert to a DCD pathway.
So, Jerry, I think that's a good point to stop the discussion. Are you happy?
Yeah.
Could everyone join me in thanking the panel that we've had up here today?
I'd like to thank Steve for doing a great job of presenting that case and steering us through it.